And let's proceed with Mr. Kondoravdis talking us about the obesity surgery, the options that we have.
Μπορούμε να το ξεκινήσουμε. So, dear colleagues, good evening. First of all, I would like to warmly thank the organizing committee of the hospital for these postgraduate courses and the invitation and the opportunity to be with you today. The topic of my presentation is sleeve gastrectomy, and I will try to explain to you why it's the most performed operation nowadays. Before I begin, I would like to welcome our guest, Mr. El Kalawi from London, with whom I had the pleasure to meet in London during my fellowship. And I'm truly happy to have him with us today. I would also like to thank Dr. Stavropoulos, Director of the First Department of Internal Medicine at our hospital, for his kind participation, and Dr. Anastasopoulos, Director of the Second Surgical Department, for his constant support and assistance in organizing this event. Thank you very much, and let's move on our topic. This is the prevalence of obesity according to worldwide organization, with 650 million people suffer from obesity, and each year at least 4 million die prematurely due to the consequences of being overweight or obese. In Greece, we have the ranking from the Global Obesity Observatory, which Greece ranks 43rd worldwide. And among the European countries, we have from the highest level of obesity, and its special consideration in which we have to take care is the obesity in children, which is persistently high and limited improvement observed over time. The effects of obesity on survival are well known, and we know that there is a correlation between BMI and survival. As we can see in these columns, at the age of 70 years, for example, there is a reduction in expectancy of life by 3 years when the BMI goes up to 32. This is the reason that the indications for surgery were updated in 2022 by a joint statement from the American Society of Metabolic and Bariatric Surgery and the International Federation for the Surgery of Obesity and Metabolic Disorders. Bariatric surgery is recommended now for patients with a BMI of over 35 without comorbidities or over 30 with type 2 diabetes. The estimated number of surgeries performed the recent years from 2011 to 2019 have a rise, and sleeve gastrectomy is the most performed operation with a percentage of 59.4%, followed by Roux-en-Y and revisional surgery with a percentage of 17, more or less. IFSO also in its survey in 2020-2021 about the current trends in bariatric and metabolic procedures marked that metabolic surgery decreased during 2020, maybe due to COVID pandemic, but sleeve gastrectomy supremacy was observed in all IFSO chapters. Laparoscopic gastric band declines worldwide. The performance of sleeve gastrectomy throughout years raised impressively from below 10% in 2008 to above 60% in 2023. The objectives of my talk is to give you an idea how sleeve gastrectomy works with weight loss, what are the criteria of a good sleeve, the evidence for the operation, hormonal and taste changes, and how to maintain a weight loss. First of all, bariatric surgery utilizes laparoscopic approach, which is with a low incidence of serious complications. you can see that the percentages of mortality and complication are low and well comparable to other well-known surgeries in our specialty, like cholecystectomy and anti-reflux surgery. We also know that even a 5% of weight loss give us a very good compliance to comorbidities, and if we have above 15% reduction in weight loss, there is a massive reduction in cardiovascular events and reduction in many forms of cancer like breast cancer, ovarian cancer, or colorectal cancer. But that's what we expect from surgery. Maybe we have a little bit higher standards. We want from our patients after surgery to lose over 50% of excess weight loss, to decrease their BMI by 35 or by 40 in super obese patients, to improve their comorbidities like diabetes mellitus, obstructive sleep apnea, hypertension, and dyslipidemias, and to have a follow-up without any complications surgically related. Finally, why sleep? Why we choose sleep? Because it's a low-risk operation, because it's a durable one, because you can do it easily and quick by the laparoscopic route. It's a low-cost operation, and most importantly, is modifiable if we need to modify it to another type of surgery. Is there any evidence for this? The evidence coming from IFSO, and summarizes its data to the following sentences. Most of the weight loss is achieved in the first 2 years with above 70% of excess weight loss for BMIs less than 50. Weight regain and gastric pouch dilatation can be seen thereafter. At 5 years, there is a sustained weight loss in the range of 50 to 60% of excess weight loss. The Achilles heel of the operation is weight regained and the so-called pouch dilatation. But as our experience shows from hundreds of patients, weight regain is rather an adaptive metabolic process seen in every bariatric operation and is not a failure in restriction. How we can control it? We can see it next. This is a comparison between sleeve gastrectomy and Roux-en-Y gastric bypass in terms of efficacy and safety in a comparative study with a total of 1,146 patients. This study results indicate that the clinical efficacy of Roux-en-Y in the management of obesity is better than laparoscopic gastric sleeve during the 11th year of experience, but the difference in weight loss and weight regain were not statistically relevant at 8 years and more after surgery. Also, a comparison of severe complications did not indicate significant differences between the two groups. And we can continue with the evidence from American Society of Metabolic Surgery, which declared since 2012, and its updated position then said that sleeve gastrectomy is an acceptable option as a primary bariatric procedure and as a first stage procedure in high-risk patients as a part of a planned stage approach. Also, there is a risk-benefit profile between BANT and Roux-en-Y. And the evidence coming from UK with a meta-analysis from 27 studies and 673 participants showed that the resolution of type 2 diabetes was in a major degree. Surgery has a strong metabolic effect to a range of 66.2%. These are in total the effects of bariatric surgery to improvements in comorbidities. We can see that according to control insulin and glucose control, and according to other lipid disturbances, sleeve gastrectomy is working well. Potential mechanism mediating the beneficial effect of bariatric surgery already said by Mr. El-Kalawi. There are gut hormones that be released and have this beneficial effect. There is a caloric reduction by the restriction sleeve gastrectomy makes, and there is a rise in energy expenditure with bile acid metabolism to be raised, fat metabolism also to alter, and to have some food and taste preferences. We don't have in this operation duodenal exclusion as in Roux-en-Y gastric bypass, and this is the common aspects of mechanism and biology that the two operations share, apart from the exclusion of duodenum and the influence in some hormones that released there. What about malabsorption? Malabsorption is something that for sure there is not the clue for sleeve gastrectomy. This has been proven by fecal and studies in animal and human. But what about Roux-en-Y gastric bypass? Is there any malabsorption? I can say that the bypass is mostly a mildly malabsorptive operation because even after surgery there is a common channel of 3 meters that allows the absorption of macronutrients at least. As for the size after sleep, this coming down from 1.5 liters to 124 milliliters at the first month and 188 milliliters at 12 months. We conduct surgery in order to create a narrow tubular sleeve with loss of the fundus, which has to be completely removed, and to create an amputation to the antrum, and which serves as a reservoir with a minimal capacity, and stomach loses its breathing functions. So the result is a rapid passage of content of stomach through the rest of the GI tract, which has some of the beneficial effects after sleeve gastrectomy. The rapid emptying, so it's threefold for liquids and twofold for solubles. This have been depicted by gastrographin studies after sleeve gastrectomy, that the contrast reaches to jejunum in a few seconds. Here we come to the part where the hormonal effects begin. With elastic gastric emptying, better longer satiety because of the rise of PYY happens, and we have a better glucose homeostasis. PYY raises because food sets in ileum more faster. Also, from GLP-1 and the incretin effect, we have rise in this particle, and we have a rapid gastric emptying with a better glucose homeostasis, as we can see. After meal, there is a fluctuation of GLP-1, which is minor before surgery, 30 minutes to 120 minutes after meal. And in the first week, you can see the fluctuation going significantly up, and to the third month, even more. As for ghrelin, fundus is the main site of its secretion, and with a proper dissection, we can move the whole of fundus during operation, making this giving to our patients a marked reduction in hunger. It's effective from the day of surgery, and there is somehow debate about how it lasts. It seems that there are 3 phases. Is the early postoperative phase, within days after surgery, that fasting levels drops by 60 to 80%. There is a medium term from 6 months to 12 months after surgery that we have persist low ghrelin levels, appetite suppression and improved satiety remain strong, and rarely return to the postoperative baseline. And is a long term, beyond 1 to 2 years, where patients' ghrelin levels remain suppressed, even after years for sometimes, and there is a gradual increase due mostly to adaptive changes in ghrelin secretion from residual gastric tissue or small intestine. The final effect of all these hormonal and restrictive changes is alterations in eating behaviors. The observed trends after surgery are reduced cravings, shift towards protein-rich and lower caloric foods, decreased response to palatable energy-dense foods, lower alcohol consumption, and preferences to more healthy choices. This suggests that gut hormones, especially GLP-1 and PYY, influence not only gives satiety, but also works as a reward value of food. And finally, this is an interesting study from UCL that examined the appetite, taste, and smell changes following Roux-en-Y gastric bypass and sleeve gastrectomy, and the correlation between them and the gender, the type 2 diabetes, and the postoperative weight loss. 253 patients underwent to the study, and 92 of them had diabetes mellitus. The relationship between food aversion changes in appetite, taste, and smell, and percent weight loss was assessed. The influence of time post-surgery, gender, and type 2 diabetes were evaluated. We can see that there are in both groups changes in appetite, taste, smell, and aversions to some food in a high degree. We can see that there is some smell changes were more common post-Roux-en-Y than post-sleeve gastrectomy. And another conclusion from the study was that no temporal effect was observed post-Roux-en-Y. In contrast, the prevalence of appetite changes decreased significantly following sleeve gastrectomy. As for sleeve, between men and women, there is a change in smell. There is a difference in smell changes, where it was significantly more common in female compared to male patients. The key findings of study are that appetite and taste changes are common after Roux-en-Y and sleeve gastrectomy. No gender effect post-Roux-en-Y, marked gender effect following sleeve gastrectomy, with taste and smell being less common in males. Taste changes also was less common in males with type 2 diabetes. Post-Roux-en-Y, there was taste changes that predicted the percentage weight loss, and post-sleeve gastrectomy, appetite changes predicted percentage sleeve weight loss. The end results is that more or less what we discussed, with better glucose regulation, lipid regulation, elevated levels of bile acids, reduction in hunger, and achievement of satiety. This is what offers the final weight loss. And we are searching to the end on how to maintain weight loss. This is happening with a few steps. First of all, it's the pre-op diet. The pre-op diet is not only a shrinkage diet, but it's also a time to make our patients understand what will happen next. It's an adaptive period, and it's important to be followed by the patients. Afterwards, there must be a close dietetic follow-up to educate patients to have good choices, to change their lifestyle, and of course to treat any pre-existing eating disorders that will make the result poorer at the end. The final key points is that sleeve gastrectomy is recommended for patients with a BMI over 35, without comorbidities, or over 30 with type 2 diabetes. As indications updated in 2022, surgery results in a total of 30% weight loss initially, stabilizing to 25% long term. Sleeve gastrectomy has an effective weight loss result and comorbidity resolution. Co-treatment with GLP-1 and other GI agonists evolves a new landscape where safety can be combined with long-term effectiveness. And to the final question, which will be the appropriate operation, for sure one doesn't fit all. It's not sleeve gastrectomy appropriate for every patient. This is clear from the number of operations exist, as well as the plethora of emerging operations. It's really pointless to argue which operation is better. Instead, we must find which is the right operation for the right patient. Thank you.